let's talk about another important topic in gynecology, that is endometrial carcinoma. The cases are increasing day by day regarding endometrial carcinoma all over the world. So in this topic, we are going to talk about how common it is, number one, then what are the causes or what are the etiology of endometrial carcinoma, how it is presenting, what are the presentation, sign and symptoms, investigation to confirm the diagnosis, and finally the treatment. Now, before we know endometrial carcinoma, we should know something about menopause and postmenopausal bleeding. Now, menopause, if I ask this question, any student can answer me. Menopause, see that meno is menstruation, pause is stoppage. The meaning is right here. This is a permanent, a discontinuation of menstruation, menopause. So 12 continuous months of cessation of menses and increased gonadotropin is the practical definition of menopause. This is a practical, okay, not a theoretical, definition. Theoretical, you can simply say permanent stoppage of menstruation is called menopause, and that can happen after the age of 45. Very confidently say that, but it depends on that lady actually. Sometimes she may still be having menstruation at the age of 50 or even beyond that. Okay, so it is individual variation. Now, one small question I like to ask you: why there is increased gonadotropin in menopause? Why? Anybody? What is gonadotropin means what? What do you mean by that? Gonadotropin means FSH and LH. Okay, now see that. Let me explain this point to you. Gonadotropin, FSH and LH. Now, what happens in case of menopause? In menopause, there's no estrogen. Ovary, they fell. Okay, ovarian functions have stopped. So there is no estrogen. Now, if there is no estrogen, the negative feedback given by the estrogen to FSH and LH, what will happen now? What happened to the negative feedback? It is weak. The negative feedback is not there. It is so weak that it doesn't exist. Okay. Now, if negative feedback is not there, then the gonadotropin, which are released by the anterior pituitary, okay, which are released by the anterior pituitary, they are increased. Okay. So the gonadotropins will be increased. Now let me repeat again. It is almost same like thyroid hormone or adrenal gland and something like that. The negative feedback concept. After menopause, no estrogen, no negative feedback. So nothing is there to stop the release of FSH and LH. So there is increased gonadotropin, and this is a very, very important concept in case of menopause. Now, menopause usually occurs at approximately 52 years of age. It doesn't matter even if you say 50, okay, or even after 45, it is still the correct answer. And postmenopausal bleeding is any bleeding that occurs after menopause. Now, you may be getting the point here. Why we have brought this issue here? What about the postmenopausal bleeding? Because endometrial carcinoma is one of the commonest cause of postmenopausal bleeding. That's why we first want to discuss about this, then enter into the topic. Now, see here, what are the common differential diagnosis of postmenopausal bleeding? Okay, or you can say, what are the common causes of postmenopausal bleeding? They include endometrial carcinoma, which we are going to talk in today's class. Another one is vaginal or endometrial atrophy. Vaginal or endometrial atrophy can also lead to bleeding, and this is also quite common after menopause because there is no estrogen stimulation. Postmenopausal hormone replacement therapy. Now, so many of the lady, they use this hormone replacement therapy, okay, just to decrease the effect of decreased estrogen hormone. So this is known as hormone replacement therapy. Means they are taking estrogen containing drug, and that can also lead to postmenopausal bleeding. Polyps and hyperplasia of the uterus, okay, both can lead to bleeding, and senile endometritis or even tubercular endometritis. Now, these are the inflammatory and infective condition. If they are present, they can also lead to bleeding. So there are so many different causes of postmenopausal bleeding. Okay, having said that, the most common cause of postmenopausal bleeding is vaginal or endometrial atrophy, which is always occurring because of very less estrogen present. And the most important diagnosis to rule out, though, is endometrial carcinoma. This is not scary, this is not dangerous to the life of the lady, but endometrial carcinoma can kill her. So make sure endometrial carcinoma is not there if somebody presents with postmenopausal bleeding to the hospital. So this is what you need to understand here. Though it is not the commonest cause, okay, but still it is a dangerous one. So I want to rule it out. Okay, let's move on. So these are, okay, the differential diagnosis of postmenopausal bleeding, atrophy, estrogen treatment, endometrial carcinoma, polyp, hyperplasia, and some miscellaneous, some senile endometritis or even tubercular endometritis. Don't need to remember the percentage here. It may differ according to different, uh, research. Okay, but see this, the atrophy is very common than endometrial carcinoma. Almost the incidence is double here. Now, let's talk about endometrial carcinoma. Now, see this. Endometrial cancer or carcinoma has recently emerged as the more frequently encountered gynecological cancer, accounting for 20 to 25% of all genital cancer in the developed countries. Now, this is the data of developed countries, not the developing one. Okay. In developing country, okay, we are from South Asia, and we are the developing countries here, and in our countries, the number one genital cancer is carcinoma of the cervix. Still, the carcinoma of cervix is very common in our countries. So please remember, this question will be asked to you during the practical type of exam. Okay, you need to be a bit of clever to answer this type of question. First, listen properly what the examiner is trying to ask there. Whereas in the developed world, endometrial carcinoma is increasing all the time. What may be the reason why in the developing world still the carcinoma of cervix is more common? Any reason for that?
Sir, it's
Multiple sex
related
partners,
with,
sir.
Okay. One is a sex partner. Any other?
and sir, also related with obesity and diabetes mellitus. That's why, sir, in Western country there is increased uses of OCPs and drugs like tamoxifen.
Okay. Now, yes, the reason he has given are absolutely fine. We are coming, okay, very soon to the causes of endometrial cancer. Is right. Obesity and diabetes are some of the important risk factors for endometrial carcinoma. Okay. Use of drugs like tamoxifen, use of drugs like estrogen, and all these things are also important causes. This is of so endometrial cancer is increasing in developed countries, whereas in the developing country, in our part of the world, why we still have cervical cancer. One of the important cause of cervical cancer is human papilloma virus. Okay. Now, what is the point here? If our people gets human papilloma virus, that is a type of genital infection, they do not go to hospital in time because of that shame, because of that, they just think what other people know about it, something like that. So they don't go to hospital. So some complication would develop. Not all strain of human papilloma virus can cause cancer, but some of them may cause. So that is a big factor why it is common in our part of the world. Number one. Number two, the regular screening which is done in the Western world, like a pap smear, is not very common in our part of the world till today. It is not commonly done. So that is another reason this cancer is not detected. This type of questions will be asked to you, okay? That's why I'm explaining here. Now let's come to the topic. The peak incidence of endometrial cancer is 55 to 70 years. This is the age group which commonly develops it. 20 to 25% occur in perimenopausal women, and only 5% develop in women below the age of 45 when they are well differentiated with good survival. Now, a little bit of confusing and long statement for you. Let me make it simple. Look at the age group which are commonly affected by endometrial cancer, 55 to 70. Now, most of them are already okay in postmenopausal age group. 55, after 55 definitely it is postmenopausal. So endometrial cancer is a cancer of postmenopausal lady, you can say that confidently. But there are certain exceptions. What are the exceptions? Around 20 to 25% occur in perimenopausal, means towards the end of the menstrual period, that cancer may start to develop and it will continue in the menopausal phase also. That is called perimenopausal woman. And only 5% develop in women who are below the age of 45, means they are in reproductive age group. And one very satisfying point there, if a reproductive age group female develop endometrial cancer, they are well differentiated and with a good survival rate. Now, what is well differentiated malignancy? What do you mean by that? Well differentiated tumor means what? Okay, probably you are not that familiar with this term. Remember, when we grade the malignancy, grading means histological appearance. We use this term. Poorly differentiated means the malignant cells do not look at all like the normal one. They are totally different. They are anaplastic cell. Whereas well differentiated means they somehow still look like a normal cell. I mean the shape and size, but the other things definitely differ from the normal cell. Okay, the size of the nucleus is big in case of malignant cell. We all know the nucleoli, size will be different. The mitosis are there. These are the hallmarks of malignant cell. So well differentiated means how well they look like the normal cell. Poorly differentiated means how different they look from the normal cell. Now, see here. Let's talk about some other important facts before we go to the risk factor. Those women are either nulliparous or of low parity. What is nulliparous? Nulliparous means what?
Who never pregnant
Never
before?
pregnancy. Never pregnant, sir.
Exactly. Who never become pregnant or who never, uh, cross the period of viability after becoming pregnant. Okay,
Still
low.
not pregnant.
Exactly,
Never.
exactly, exactly. Or low parity means, okay, probably what is low parity? Very few birth, isn't it? Very few birth are given at low parity. Or probably, they have tried, but it's still not happened. So all these different things are there. Now, let me come to the point here. Why these people or these ladies have more chance of developing endometrial cancer? Because of unopposed and prolonged exposure to estrogen hormone. This is a very, very important concept to understand here. Now, prolonged exposure to estrogen hormone is the single most important, a pathogenetic mechanism for endometrial carcinoma development. If we provide them progesterone, or if the body is naturally producing progesterone, probably it is balancing the effect of estrogen, and the effect of that unopposed estrogen would be less. So there is decreased chance of endometrial cancer development. Endometrial cancer is poorly differentiated in postmenopausal women, whereas in young women it is well differentiated and curable. Important fact again, that's why they have got good prognosis, especially if they develop in reproductive age group. After the age of 80, the incidence drops. So these are some of the important epidemiological point. Now, what are the predisposing factors, or if they ask what are the causes, okay, you can highlight them. Predisposing factor or the causes. Now see here, any factor that increases the exposure of endometrium to unopposed or high estrogen level, both endogenous and exogenous, increases the risk of endometrial cancer. Very, very clearly written. So if we give only estrogen, that is quite fatal for the development of endometrial cancer. If it is given for a prolonged time, it is fatal. And both endogenous means, it is released internally, or exogenous, if she is taking only estrogen containing drug from outside, that can also be damaging. This is also linked to dose and duration of the exposure. If someone is taking that for years, definitely that has more chance of developing endometrial cancer. And if you take this at high dose, that is also causing more chances. Unopposed and unsupervised administration of hormone replacement therapy after menopause predisposes the woman to endometrial hyperplasia and cancer. Hyperplasia always comes first, you know that. Okay, hyperplasia means increased number of cells. Estrogen is doing that. Later on, some of them may develop into cancer cells and then simply multiply. Fortunately, the malignancy is well differentiated with good prognosis if it is caused by this hormone replacement therapy. Okay. Chronic non-ovulatory cycle, as seen in abnormal uterine bleeding, may be another predisposing risk factor. Now see here, non-ovulatory cycle. Let me explain this. Many of the lady, they don't develop ovulation. Now after ovulation, which hormone comes out from the ovary? Which hormone?
Strong after ovulation.
Now after
Progesterone, sir.
Progesterone, sir.
exactly, estrogen will continue. Okay, estrogen is already there. Estrogen is there right from the beginning, isn't it? But at the 14th day of menstrual cycle, ovulation occur. Now that Graafian follicle, which is left behind, will develop into corpus luteum, and that corpus luteum will secrete progesterone hormone. So always remember one important fact here: if the lady is ovulating, then she is secreting progesterone hormone as well, and that progesterone hormone is somehow protective in the causation of endometrial cancer. Now the opposite point is also true. Chronic non-ovulatory cycle means only estrogen stimulation, no progesterone, is an important cause of endometrial cancer. In some family, a strong familial predisposition is noticed. This is a familial cancer development. Okay, this is a very interesting term here, which is known as Lynch syndrome, familial Lynch syndrome. So let me talk a little bit about this. This familial Lynch syndrome is also known as hereditary. Okay, let me write here, hereditary. Okay, non-polyposis. Exactly. Very good. Hereditary non-polyposis Colorectal cancer. Excellent. Colorectal cancer syndrome. Now see there. Hereditary non-polyposis colorectal cancer syndrome. So let me clarify this. What does that mean? Though the name of only colorectal cancer is here, please don't get confused. It is associated with so many other cancer development in our body. And it runs in the family as an autosomal dominant disorder. The hereditary pattern is autosomal dominant. That means if father or mother is carrying the gene, there is 50% chance that offspring will carry the same gene. This is called Lynch syndrome. Now, what are the common cancer which develops in this condition? One of the cancer which we are talking right now is endometrial cancer. The colorectal cancer name is already there. Okay, so these are the two very easy names for you. Apart from them, breast cancer, pancreatic cancer, carcinoma of the stomach, okay, even the other types of colon cancer, lung cancer, so many other, prostate cancer, even kidney cancer, so many of them can develop in Lynch syndrome. And one very important point, a cancer develops before the age of 50 in this condition, which is quite rare. Cancer usually develops in older people, but in Lynch syndrome, it develops before the age of 50, and multiple members of the same family may develop it. Okay, now what may be the cause for this? Mutation in some of the gene in our body, which may be transmitted as autosomal dominant pattern, may be responsible for Lynch syndrome. Now, another important point, okay, which I need to discuss here is, see this, the estrone is derived by peripheral aromatization in the fat tissue from androstenedione and contribute to a high level of estrogen in some of the lady, okay, who are genetically predisposed. Now see this. What is the source of androstenedione in our body? What is the source? This is known as sex steroid or androgen. What is the source? In female body. Yes, from where it comes in female body?
Ovaries.
Sir, the ovaries and the adrenal glands are mainly.
Exactly. Adrenal gland is the more common sources than ovary. Okay, adrenal gland. Ovary is responsible for estrogen. You all know that. But androgen, the predominant source is adrenal gland. Remember that adrenal cortex. There are three zones: zona glomerulosa, zona fasciculata, and zona reticularis. That zona reticularis layer of adrenal cortex is responsible for androstenedione secretion. Now, what happened to that? Okay, the fatty tissue can aromatize that or can convert that into the estrogen hormone, but it doesn't happen in everyone. Yes, a small amount may be converted to estrogen in everyone. That's why even after the menopause, the estrogen level may be present a little bit in the female body, but in some people there is a genetical predisposition so that they will convert this androstenedione into a large amount of estrogen, and that may be responsible for the cancer development. Now, tamoxifen is a drug which is responsible for endometrial hyperplasia and cancer development. Now, this is a very interesting fact. This tamoxifen, by the way, is anti-estrogen drug. The use of this tamoxifen is in the treatment of breast cancer. See this. Okay. So how it causes endometrial cancer? Because right now what we are saying, if we block the effect of estrogen, then probably, okay, the chances of endometrial cancer should be less. That's what we are talking till now. So this is a contradictory to our discussion. Okay, so listen properly. Though this tamoxifen is anti-estrogen drug, but it has estrogen-like effect in the endometrium. It acts like estrogen-like drug in the endometrium, and that's why it can have, a chance of endometrial hyperplasia and cancer to 2 to 3 fold than the person who is not taking it. Another, similar looking drug, raloxifene, has no adverse effect on the endometrium like tamoxifen regarding this case. And this tamoxifen is a very common drug used in the treatment of breast cancer. Okay, remember the name. Combined oral hormonal pill have a protective effect and reduce the risk by 40 to 50%. That's what I was talking about. The progesterone, which is present in this combined oral contraceptive pill, is a protective in nature. But if somebody is taking only the estrogen containing pill, that risk is definitely high. Obesity is one of the risk factors. Okay, obesity. What is the mechanism? Maybe obesity reduces the level of serum sex hormone binding protein and allows the free estrogen to circulate in the body. So this is the mechanism. Obesity decreases the level of serum sex hormone binding protein and allows the free estrogen to circulate in the body. Moreover, the peripheral conversion of epiandrostenedione or simply androstenedione is aromatized to estrone in the peripheral fat, which is of course more common in obese people. This mechanism I just explained to you. Sometimes the genetically predisposed people, they convert more, androgen into estrogen, and of course the chance will be higher in them. But some other will also do that, especially the obese people. At the same time, hypertension and diabetes are also associated with the increased risk of endometrial cancer development. Okay, but why? How are they associated? It is very poorly understood. Okay, probably one reason we can give is, look at this obesity. Obesity itself can lead to hypertension. Obesity can itself lead to diabetes. Okay, so probably these are the linking phenomena here. Let's move on. Now, what are the other, predisposing factor apart from them? Infertile women and women with polycystic ovarian syndrome on account of non-ovulation have high estrogen level. So there is a definite more chance of endometrial hyperplasia and endometrial cancer than normal women. So you must have heard about this term before, polycystic ovarian syndrome, also known as Steen-Leventhal syndrome. So let me write that term here. Steen, okay, Leventhal syndrome. Now, what is this? Let me talk a little bit about this. Steen-Leventhal syndrome or polycystic ovarian disease or syndrome is the condition where there are multiple cysts present, okay, inside the ovary. And these ovaries, they usually do not ovulate. Okay, they keep on secreting increased level of estrogen. At the same time, they are responsible for the secretion of androgen as well. So there is increased estrogen and there is increased androgen in the female body in case of polycystic ovarian syndrome. So see here, increased, okay, estrogen and androgen. Now, this increased estrogen is responsible, okay, for endometrial hyperplasia and endometrial cancer. This is well known fact by now. But what this increased androgen is doing to that lady? Anybody? What happens if there is excessive androgen level in the female body? What happens? How I know there is excessive androgen in female body? What clinical feature they show?
Excessive muscularization
Sir,
and hirsutism.
sir, they will say the male feature, sir, the
Very
male
good.
feature like hirsutism, sir, mainly.
Exactly. You both are right. This is known as masculinization and features of hirsutism. Absolutely correct. So if I clearly examine that lady, she has unwanted hair growth on her face. just like a mustache in case of male, a similar type of hair growth, beard, grow on her face. That is very abnormal for a lady. Okay, so and there is a change in voice quality. She develop a little bit of muscle mass. All these features are because of androgen presence in her body. So a good doctor will definitely think from where the androgen is producing in our body. Okay, and if we take a good history and physical examination with the help of investigation, we'll definitely diagnose polycystic ovarian syndrome. Okay? And treatment is usually by surgery. Okay, you remove those cysts from the ovary. This is a very interesting condition. We'll talk about this when the appropriate time comes. Now let's move on. The uterine fibroid is associated with endometrial cancer in 3% after the age of 40. Now the mechanism of both is same actually. Uterine fibroid is also associated with increased level of estrogen, whereas endometrial cancer is also caused by the same mechanism. Okay, so they may coexist together. That is one fact. Okay, and another one, see this 3%. Okay, endometrial cancer can occur along with uterine fibroid as well. Basically, the linking process here is the same mechanism. Okay, other fact is not there. 15% women with endometrial cancer have feminizing ovarian tumor at the time of diagnosis. Now, feminizing ovarian tumor means estrogen producing tumor. So this estrogen producing tumor, of course, has a high chance of development of endometrial cancer. Now, I will take a big class about ovarian tumor, okay, in gynecology. This is a very important lecture. And in that ovarian tumor, there are so many different types. One of the type of ovarian tumor is called granulosa cell tumor. That granulosa cell tumor is producing large amount of estrogen. So who knows, some lady may be having ovarian tumor along with endometrial cancer together. Let's move on. Now, to summarize this discussion or these risk factors which we have talked till now, look at here. These are the etiology and high risk factors. Unopposed estrogen or high level of estrogen, probably the single most important point here. And all other things are related to that. Chronic anovulation. Chronic anovulation. The ovulation is not happening. So there is no protective effect of this progesterone. Only estrogen is there. PCOD, polycystic ovarian disease. Polycystic ovarian disease, also known as Steen-Leventhal syndrome. Familial predisposition like Lynch syndrome, or even without Lynch syndrome, some lady may be converting that androstenedione or androgen excessively into the estrogen, which may cause the problem. Tamoxifen, though it is anti-estrogen drug, okay, in the uterus or in the endometrium, it may stimulate just like estrogen. Obesity, hypertension, and diabetes. These are the risk factors, okay, which increases the chance of having endometrial cancer. And probably because of this factor, this cancer is increasing in the Western world because there is a high incidence of these diseases in the Western world. But our part of the world is also increasingly having this type of diseases. Feminizing ovarian tumor like granulosa cell tumor, which is secreting estrogen. Low parity and late menopause. Again, these are associated with increased unopposed estrogen level. Now, what is the pathology of endometrial cancer? So let's talk about it. Endometrial cancer may be localized in one area of the endometrial cavity or diffuse. Localized or diffuse. Quite easy to remember. It may appear as a nodule, a polyp, or a diffuse lesion involving the entire uterine cavity. Of course, the last one is a bit of dangerous one. So appear as a nodule or a polyp in the beginning, and later on maybe a diffuse lesion involving the entire uterine cavity. It may extend, see here, it may extend towards the endocervix in the advanced stage and even invade the myometrium to a varying degree. So endocervix means endocervix is a part of cervix. We all know, we have studied that before. Cervix is divided into two parts, ecto and endocervix. And cervix is the lower part of the uterus. So it is extending downwards in the advanced stage. And in the advanced stage, it also invades the myometrium. And then it may even reach the perimetrium and from there outwards. That is a, uh, stage 3 or stage 4 type of endometrial cancer. It spreads to the adnexa, ovaries, as well as to the pelvic and para-aortic node. So these are the places where the malignancy metastasizes. In the beginning, local invasion, then metastasis. The fundal growth spread to the para-aortic lymph node via the ovarian lymphatics and also to the superficial inguinal lymph nodes via the round ligament. See, these are attached. Round ligament is attached to the fundus area. So through that, it may reach the superficial inguinal lymph node. Now, what is the connection of round ligament and superficial inguinal lymph node? Who can answer that to me? Where round ligament will go? Where it attaches? Where it ends? Let's talk like that. Where it ends?
Sir, labia majora attached with it ends.
Very good. It ends in the labia majora. And from where it passes? There is your answer.
From inguinal canal, sir.
Excellent. From the inguinal canal. So it enters into the deep inguinal ring, passes through the inguinal canal, comes out the superficial inguinal ring, and that area you have superficial inguinal group of lymph node. So always, these lymphatics, they follow some of the structure and they lead those tumor cells to that area. Okay. Similarly, this para-aortic lymph node are affected through the ovarian lymphatics. Distant metastases occur in the lung, liver, brain, and bone. So this is a serious type of cancer. If it is not detected in time, it can lead to very distant metastasis as well. Now, histologically, what type of tumor is this? What type of malignancy is this? Now, see this. Endometrial cancers are adenocarcinoma in 75% of the case. Means these are gland-forming tumor. Adenocarcinoma are gland-forming tumor, where there are lots of gland presence, or the tissues or the tumor cells are arranged like a gland. The rest are clear cell, squamous cell with a serous variety, which are more malignant than adenocarcinoma. These are exceptions. Even if you don't remember these, it doesn't matter because they are exceptional type. The grading of these tumor. Now, grading, let me remind you once again, staging and grading of the malignant tumor is very important concept. Grading is done with the help of microscope. Okay, we need to detect what is the histopathological structure there first. Okay, that is called grading. Staging, how far the malignant tumor has spread from its area, that is staging. So the grading of this tumor is based on differentiation, glandular architecture, and anaplasia of the cell. And adenoacanthoma is least malignant among all of them. This is just one variety of adenocarcinoma. So differentiation, how well the tumor cells, look like the normal cell. This is differentiation. Architecture, how well they are organized there. It is all about organization. And anaplasia means poorly differentiated cell or the most malignant cell. Necrosis in the tumor has an adverse effect on human survival. Okay, necrosis in the tumor has an adverse effect on the woman survival. Now, the reason we can give here is probably there is decreased amount of blood flow, decreased amount of blood flow to that tumor mass, but some cells are still there, isn't it? It's all cells that do not die, only few of them. And if the blood supply is not proper in that particular area, if we are using certain chemotherapeutic agent, then that may not reach that particular area. So there is still some chance of survival of the cells. So the prognosis is not that good. Now we are coming towards the end of this class. Remaining part will be dealt in the next time. So there are two varieties of endometrial cancer. We already talked about this though. Those two varieties are type 1 are estrogen dependent tumor, okay, and type 2 are estrogen independent tumor. So type 1 are estrogen dependent, they account for 90% of the growth. So of course they are more common. And from the very beginning of this topic, we have been talking about this. These are estrogen dependent tumor. Okay, so of course they are most common one. The source of the estrogen in this case may be endogenous or exogenous. Now, what is this endogenous source? Let me ask this question again. From where this estrogen is coming? Yes?
From the ovary, sir.
Okay. In the reproductive age group from the ovary, but after the menopause, from where it comes? After menopause. From where it comes after the menopause, in case of postmenopausal lady. Okay. So remember, it may come from some tumor which is secreting estrogen, like ovarian tumor. Who knows? Ovarian tumor is there and it is secreting large amount of estrogen. So see there, quick thinking is necessary. Okay. And another one, remember, androgen will be converted into estrogen in some of the lady who are genetically predisposed. A small amount is converted in all of them, but a larger amount, okay, we need certain genetical predisposition factors. So these are endogenous sources of estrogen I'm talking about, okay? And exogenous means from outside, like a estrogen containing drug, the pills which are only having estrogen. That was the answer. So they are well differentiated with a good prognosis, the estrogen dependent one, especially if they occur in the reproductive age group, they still have or even have better prognosis. Type 2 are estrogen independent endometrial cancer, and they develop in atrophic endometrium. They are mostly undifferentiated with poor prognosis. So some of the endometrial cancer still develop in the atrophic type of endometrium, and they have very poor prognosis in comparison to the type 1. What are the clinical features of endometrial carcinoma? Share. Endometrial cancer may be asymptomatic in 7 to 10% to begin with, and later on it may manifest as menorrhagia or irregular period in the perimenopausal woman. So this is the common age. Okay. After menopause is the commonest age, then perimenopausal woman, then sometimes very rarely it can also occur in the reproductive age group. So how it manifests? Menorrhagia or irregular period in perimenopausal woman. And the lady who already developed menopause presents with postmenopausal bleeding. So postmenopausal bleeding is always abnormal, always. Though endometrial carcinoma is not the commonest cause of postmenopausal bleeding, but it has to be ruled out because it is quite, lethal or dangerous to the life of that lady if not treated in time. Okay. This is the point which we discussed last time. There may be history of PCOS. Okay, what is PCOS?
Polycystic ovarian syndrome, sir.
Very good. Polycystic ovarian syndrome, or you can also call it polycystic ovarian disease. So PCOD or PCOS, both are synonymous thing. Or hormone replacement therapy, HRT, may be elicited, definitely. Especially if this hormone replacement therapy only consists estrogen, the danger is very high. And PCOS, okay, it secretes more hormone, Along with that, androgen hormone is also there. We'll take a class about PCOS very soon. The woman may be obese, hypertensive, or diabetic. So all of these are associated factors, and pain and lumps appear late in the advanced stages. Advanced stages means late stages, stage 3 and stage 4. Let's move on. Now, apart from those, some other clinical features would be bulky uterus. Bulky means enlarged uterus, okay, bigger in size. That is called bulky. See that. Now, bulky uterus may not always be present because sometimes the growth is, a bit disseminated there along the line of the endometrium. So the uterus is not that very big or massively enlarged. Sometimes this bulky uterus is due to some other reason. Okay, the endometrial cancer is the culprit, but it is not purely, responsible for the enlarged uterus. It may be due to associated fibroid or pyometra. So these may be the causes. Now, remember, the pathogenesis of fibroid and endometrial carcinoma is a bit similar. Unopposed estrogen is responsible for both of those situations. That's why the same lady may be having fibroid and endometrial cancer. Pyometra is the collection of pus in the endometrial cavity. Now, this is associated with infection definitely. So, who knows? First of all, there is malignancy, then that has attracted infection, and that infection has got pus collection, which leads to enlargement of the uterus. So, these may be the other causes of uterine enlargement. Okay, we are talking now. An adnexal tumor is often a feminizing tumor if present. Now, adnexal tumor means, ovarian tumor, which may be there. That ovarian tumor may be hormone secreting tumor or estrogen secreting tumor, and that may be responsible for, the endometrial cancer. So who knows, that may be there when we examine. In the advanced stage, the cervix become bulky and the os is patulous with the growth protruding through the external os as well. It depends which type of growth is there. Okay, if it is a polypoid type of growth, then it may happen like that. A metastatic vaginal growth is visible near the urethra, and a benign polyp can undergo secondary malignant change as well. So sometimes metastatic vaginal growth is also seen there. Now, one very important point, the clinical point, this is discovering lower genital tract lesion in a postmenopausal woman doesn't rule out endometrial cancer. Both may exist, and investigations are required to rule out endometrial cancer. So this is important. So what does the meaning? Discovering lower genital tract lesion in a postmenopausal woman doesn't rule out endometrial cancer. Now, we simply do not treat for genital tract lesion only. Okay, we have to rule out endometrial cancer there. That is the meaning. Both may exist together. So always, do the proper investigation to rule out endometrial cancer in postmenopausal women. If they present with a slight amount of bleeding, some amount of other lesion there in the genital tract. Now, what are those investigations we like to do? Okay, one of that is pap smear. Now, pap smear, frankly speaking, is not done for endometrial cancer. Okay, it is exclusively done for carcinoma of the cervix or even the CIN, the cervical intraepithelial neoplasia stage of carcinoma of the cervix. But we can pick some of the endometrial cancer cells even by pap smear if they are coming downwards. Now, pap smear is only 50% sensitive and not reliable for the confirmation of this diagnosis. And if we are lucky, these endometrial cells or the cancerous cells reveal large round cell with dark nuclei. These are the appearance of the cancer cell. Aspiration cytology from the uterine cavity 6 monthly is the effective screening method in high risk cases. So if pap smear is the screening test in CIN and cervical cancer, aspiration cytology is the screening test in endometrial cancer. Okay, especially in the high risk cases and those who are taking tamoxifen and HRT. Now, in the last class, we talked about tamoxifen. Remember, what type of drug is tamoxifen?
Sir, anti-estrogen drug.
That is
Exactly, anti-estrogen drug. Very good, anti-estrogen drug. But it has an anti-estrogen property somewhere else. But in the endometrial cavity or the endometrium, it acts just like estrogen. That's why it is a risk factor for endometrial carcinoma. The aspiration is done with a Pipel curette, Isaac aspirator, and Vibra aspirator. So you don't need to remember these names. These are purely practical type of knowledge. So these are the name of the instrument which are used for the aspiration. Another investigation is fractional curettage. Fractional curettage. What does that mean? It comprises histological study of endocervical scraping before dilating the cervix, followed by cervical dilatation and curettage from the isthmus, body of the uterus, and fundus separately so that the extent of the lesion can be evaluated. So first of all, they take endocervical scraping, then they dilate the cervix with a dilator. Okay. Later on, we'll talk about dilatation and curettage when we reach to that appropriate topic. This is one of the major form of surgery, okay, or procedure in case of gynecology. We call it DNC, dilatation and curettage. So what we do first, we dilate the cervix, we take the curette, insert the curette into the endometrial cavity, okay, and take curettage from different area like isthmus, okay, body of the uterus and fundus, and then send that sample to the lab. Now, another type of investigation would be hysteroscopy and the biopsy. Now, this is endoscopy of the uterine cavity, hysteroscopy. And with the help of that, if any suspicious area is there, we can take the biopsy. Okay, so we can confirm it. Another is ultrasound. Ultrasound is a very simple and a routine test which is done in this type of disorder. So ultrasound is useful in studying the endometrial thickness, how thick it is it irregular or not, are there any polyp present or not, and are there any associated ovarian tumor or ovarian metastasis or not. So many information is provided by ultrasound. So it is routinely done. And extension to the cervix can also be recognized here. Now, one very important practical information, please, this can be asked as an MCQ question also in the exam. In a postmenopausal woman, the normal endometrial thickness should not exceed 4 millimeter. Now, why is that? Because in a postmenopausal woman, there is no estrogen. Without estrogen, the endometrium get atrophied. So, it is very less in thickness. Quite easy to understand. And 10 millimeter in a perimenopausal woman. So perimenopausal means around the period of menopause. Okay, still there is some effect of the estrogen. So the upper limit is 10. So if it exceeds 4 mm in postmenopausal woman, and if the thickness exceeds 10 millimeter in perimenopausal woman, that gives the diagnosis of endometrial thickness. Okay, endometrial hyperplasia, endometrial hypertrophy means there is probably the effect of estrogen there. Estrogen is active from somewhere. The lady is taking estrogen probably from outside as a hormone replacement therapy, or maybe she is having estrogen secreting ovarian tumor. Okay, something, some reason is there, and then we have to take that for histopathological study. Now, this picture is telling us how to do hysteroscopy. So see that this is the instrument called as hysteroscope. See this, It is inserted from the vagina through the cervix into the endometrial cavity, and it can detect whatever abnormal pathology is there. And if it is there, then we can take the biopsy as well. So it is just like doing endoscopy of the uterus. Now, see this hysteroscopy has detected submucosal myoma in this case. This is a big myoma here. Okay, myoma is a fibroid, and I just told you fibroid and endometrial cancer can occur together. Now, this is another picture of the hysteroscopy which shows endometrial atrophy. So this pale looking endometrial atrophy. This is the common feature in case of menopausal women. And sometimes even from this atrophic endometrium, the endometrial cancer can develop, and that has got poor prognosis. Now, this is another investigation which is the sonosalpingogram. Okay, sonosalpingogram, or simply ultrasound. First they do ultrasound and then they measure what is the thickness of the endometrium. See this is how it is done. It's difficult to explain right now because you need to learn all the arts of ultrasound here. This white strip is the endometrium. Around this is a cavity actually, and around this a bit of density difference is the endometrium. So this is a thin one, and here is the very thick one. See this is a thick type of endometrium. So definitely it is endometrial hyperplasia. Now I want to explain another type of investigation which is done a bit similar. This is known as sonosalpingography. Okay, sonosalpingography. So what we do here, see this, we put a small Foley's catheter, okay, through the vagina into the cervix, and then we put normal saline into the endometrial cavity. Okay, then you do the ultrasound. Now that will easily pick up if there are any polyp or any other pathologies there. That is called sonosalpingogram. Doppler ultrasound can also be done. This is another investigation. These all are different, parts or types of ultrasonographic exam. Now, what is CA125? What is that? It is
So it is a sort of tumor, like sir, when it is elevated, so there will be presence of any tumor in there.
exactly. Okay.
Carcinogen.
Exactly.
Cancer antigen.
Exactly. So this is a type of tumor marker, and all of you, if I ask this question, I'm sure everybody can answer this. The importance of tumor marker. Now, let me repeat again. Number one, it is helpful for the diagnosis. It is helpful for the diagnosis of the malignancy. Number two, it is important to know for the recurrence also. Recurrence means cancer is coming back uh, after the treatment. Some cancer cells are left behind. Treatment is probably incomplete. Surgery was not properly done, something like that, or metastasis has already occurred before the treatment started. So cancer will recur, and that is also known by increase in tumor marker level. And third one, when we start, treatment in the patient, the level of the tumor marker should fall down from the previous stage, previous level. That means our treatment is working. So there are three important points regarding tumor markers. In this case, it is raised, okay, above 35 international unit per ml. You don't need to remember this level because it is provided in every investigation form these days, but not in all, and is not specific for endometrial cancer only. Sometimes ovarian cancer can also have increase CA125 level. Now, another type of investigations are CT and MRI. You don't need to know in so much detail regarding CT and MRI, but they are routinely done in this type of cases because of the staging. We need to know what is the staging of this malignancy. Is it stage 1, stage 2, stage 3, or stage 4? Is it early stage or advanced stage? So for that, CT and MRI are routinely done. In the exam also, okay, if we ask the investigation, you don't need to explain. Just write 1 or 2 line actually regarding the important point. That's it. These extra things are for your knowledge, not from the exam point of view. So already talked about MRI. Okay, MRI is very sensitive and specific, especially in detecting the myometrial involvement and nodal involvement. Now, some other test we can do is X-ray of the lung and bone. Now, these are mainly done for the staging purpose again, for the staging purpose. For example, if distant metastases have occurred in the lung or the bone, we can detect that by X-ray. Rather than X-ray, if the facilities are available, if they are there, then PET scan. Okay? This is positron emission tomographic CT scan. They are wonderful. They reveals metabolic activity in the tissue and is a gold standard investigation for staging. This is called PET scan, very common term, regarding the radiological investigation. Now let's talk about what is the staging of endometrial cancer. See there, these are the different stages. Stage 1, in this the patient presents most commonly, and here the spread is limited to the uterus. Stage 2, extension to the cervix. Stage 3, spread adjacent to the uterus, and stage 4, spread further from the uterus. This is very easy knowledge, okay, and you can exactly remember like this to make your concept. If we want to elaborate this a little bit, okay, now see here, stage 1, spread limited to the uterus. This is the most common stage of diagnosis, and it is again 1A, 1B. 1A is limited to the endometrium or invasion less than half of the myometrium, and 1B is invasion more than half of the myometrium, but it is still in the uterus. It has not gone out of it. Stage 2, extension to the cervix but not outside the uterus. This is stage 2. Stage 3, spread adjacent to the uterus. The adjacent means adnexa. That is called adnexa. Okay, so it is invading the serosa or adnexa, or having positive cytology. During the investigation, we have detected it. 3B, invasion of the vagina, and 3C, invasion of pelvic or para-aortic node. Now it is going a bit far away. Okay, so already a bit complicated now. And stage 4 is the most severe one, spread further from the uterus, like inverse the bladder or rectum, and 4B means distant metastasis, like lung, bones, and other organ. So a bit similar to the staging of cervical cancer actually. Now the last part is the treatment. So how we are going to treat these cases. First is surgery, and surgery is the most important treatment here. Now what type of surgery we do? Abdominal hysterectomy, bilateral salpingo-oophorectomy, omentectomy, and pelvic as well as para-aortic lymph node sampling. These are the cornerstone in the management of early endometrial cancer. So if cancer is detected early, for example, stage 1, and if we do this type of treatment, patient can survive. Prognosis is really good. Now let me explain this. Abdominal hysterectomy is removal of the uterus through abdominal route. Okay, there are 2 types of route or 2 types of hysterectomy according to the route. One is abdominal, another is vaginal. So this is done definitely through the abdominal one. Bilateral salpingo-oophorectomy means both sides, fallopian tube and ovary are also removed. They are also removed. This is known as bilateral salpingo-oophorectomy. Omentectomy, the omentum is also removed, greater omentum, and the lymph node are also removed. So this is a massive type of surgery, a bit like a radical type of hysterectomy. Post-operative radiotherapy is another type of treatment. Now, it depends upon the surgical pathological findings and staging, whether we are going to do it or not. It is usually done in advanced type of stages. Now, what are the different way of giving radiotherapy to the patient? Here, stage 3 and 4 are not operable case because there is local invasion, already metastases have occurred, the cancer has gone out of the uterus. So these cases are not operable, means surgical therapy is not possible here. So they are treated with brachytherapy followed by external radiation. This brachytherapy means the radiation material or those radiation substance is kept inside the tissue itself. They are kept there. So they destroy or damage the tissue by releasing those radioactive substance. This is known as brachytherapy. And this is done by packing the uterine cavity with Hayman capsule. Okay, this is a form of treatment in case of brachytherapy, a part of radiotherapy. At the same time, adjuvant chemotherapy and progesterone therapy. This is the progesterone, okay? Prolong the remission and improve quality of life. Progesterone is one of the important drug here. And we have explained the role of progesterone in this cancer, if you remember. Progesterone will antagonize the effect of estrogen. And everything is done here mainly by estrogen, remember that, okay? So if we antagonize the role of estrogen, and that is the treatment in this case, that is the role of progesterone. Hormonal therapy is non-toxic and does not need hospitalization, especially progesterone. Now, which progesterone we like to give? These are the example. Just remember the name, okay? No dose, nothing. How long, you don't need to know now. Medroxyprogesterone acetate or 17 alpha progesterone or norethistérone are the drug. Simply remember norethistérone, this is another name, and progesterone acetate, medroxyprogesterone acetate, MDPA or norethistérone. These are the type of progesterone which can be used. Now let's summarize. Okay, let's make it very easy. And these are the take-home messages. See here: stage 1, stage 2, stage 3, and stage 4 of endometrial cancer, and these are the treatment which is done. Now, total abdominal hysterectomy and bilateral salpingo-oophorectomy. This can be done for all stages. Having said that, in stage 3 and stage 4, okay, there is extensive local invasion and there is already a bit of metastasis occurred. So we judge according to the cases. If doing surgery is more damaging for the patient, sometimes it is doing more damage for the patient, then don't touch that area. Just start palliative form of therapy like radiotherapy or chemotherapy or progesterone therapy. But if still going to help the patient, then debulk the tumor, remove some part of the uterus, do those necessary treatment. It may help the patient. This is the concept. So we cannot generalize the thing here, okay? Only this type of therapy is done for this stage. It's not like that. It depends on so many things, and it depends on the the treating gynecologist and the oncologist. Now there is another slide, okay, which is again summarizing very easily what are the necessary treatment for this type of conditions. Remember, in the beginning, there may be endometrial hyperplasia before the endometrial carcinoma occurs. So we simply treat with progesterone. Progestin means progesterone. Complex hyperplasia, again by progesterone. Complex hyperplasia with atypia, now it is going towards the cancer. Atypia means the cells are not organized properly. We go for hysterectomy. We don't want to take any chances. Okay, and progesterone can be given together. And if endometrial carcinoma is diagnosed, then total abdominal hysterectomy and bilateral salpingo-oophorectomy is the treatment. So all of these are caused by unopposed estrogen. Now, lastly, what is the prognosis? What type of cancer is this, and what is the success rate in the treatment? Depend on the histology of the tumor, depend on the grading, myometrial infiltration, and pelvic node involvement and overall staging. Stage 1 has 5-year survival rate of almost 75%. Now, this is a good one. Okay, we consider this 75% as a good chance of survival in stage 1. That's why early diagnosis is so important point here. Okay, but it reduces to 10 to 20% in stage 4. Stage 4 means already metastasized, so 10 to 20%, drastic drop. Stage 2 survival rate of 55% and stage 3 survival rate of 30% is reported. 30 is already poor. 55 is also low, but it is well acceptable than stage 3 and 4 survival. So these are a very, very important point. It is important that a woman who has been treated for uterine malignancy should not be offered hormonal replacement therapy for menopausal symptom, because you are aggravating the situation there, because it has got estrogen. Estrogen should not be given in this case. Now, prophylaxis, okay, can be given in this case, in case of high risk causes or high risk ladies, and that is done by progesterone. Progesterone is the drug which is antagonizing the effect of estrogen. So the different forms of progesterone can be given. One is by oral combined pill. It has got progesterone, and see that it reduces the cancer risk by 40 to 50%. Another is hormonal IUCD. This is intrauterine contraceptive device. Intrauterine contraceptive device. Now, what does that mean? This is a form of contraception which can be kept inside the uterine cavity. Okay, this is a type of progesterone again. So similarly, if a lady is getting tamoxifen, okay, now tamoxifen almost acts like estrogen in the endometrial cavity, so it will lead to endometrial thickness or endometrial hyperplasia. So why don't we replace this tamoxifen with raloxifene, because raloxifene doesn't have this type of effect. So all of these points are regarding prophylactic treatment of endometrial carcinoma. So let me summarize with a few sentences now at the end. Okay, this is a little bit difficult type of cancer than cervical cancer, but please make your concept clear. Repeat 1 or 2 times, then it would not be very difficult. The endometrial carcinoma is caused by estrogen. Never forget this. Whatever conditions or risk factors are there which leads to increased estrogen, unopposed estrogen, it can lead to endometrial cancer. And this is the carcinoma of menopausal ladies after the menopause. These are the most common population. But sometimes perimenopausal women, or very, very rarely, even the reproductive age group female can develop endometrial carcinoma. There are other risk factors apart from estrogen also. And after doing the staging, after doing different investigation, after doing the different staging, we plan for the management. The most important part of the management is surgery. Okay, surgery. In stage 1, it is almost curative, and the surgery is total abdominal hysterectomy with bilateral salpingo-oophorectomy, a bit of omentectomy, and whatever lymph nodes are involved, we need to remove all of them. Okay, that's the treatment. And when the lady is presents with the higher stages, then you can add some other drugs like progesterone, some chemotherapeutic agent, okay, radiotherapy, and those type of things. Okay, so let me stop here. Okay, so at the end, I like to request you all to like the video as much as possible, share it among your friends, and subscribe to the channel so that it will encourage me a lot for the future videos and recordings. Thank you so much.